Oh, yeah,
Here we
thank
go.
you. Okay, so welcome everybody. I'm thrilled to be here. This is actually fun for me. I've been doing family medicine for 29 years, and my wife and I met in 2011. We'll go over that, but it actually, February of this year was the first time I spoke in front of a crowd of people who are doing keto. Before that, I was always talking to doctor groups and saying, guys, we're missing the boat, and we need to do better. And my response was kind of like crickets. So, it's nice to be in a crowd of people who are like-minded. So, basically, it starts with me getting interested in medicine. At 17 months old, I started medical school.
Let's get that on the full screen.
Yeah, do the full screen thing.
How do we do it?
Hit F5.
Hit slideshow. Yep.
F5? Oh, where'd it take it?
There it is, there it
Oh,
is.
there we go.
Takes
He
a
knows,
moment.
listen.
All right. So I started medical school at 17 months old, Medical College of Georgia. Actually, that was my dad, but I was kind of along for the ride. And in the 4th grade, I asked my dad where babies come from, and he gave me such a discussion about it, words that I had no idea what he was talking about, so I got guidance textbook of physiology and a medical textbook, and I kind of figured this thing out. At 12, I learned to read EKGs, which was also the year, by the way, that Atkins' book came out. So as a doctor's kid, you go to the doctor's events, you go to the doctor's lounge at the hospital, and you hear the talk. And the talk was that Atkins was going to kill everybody. Now, I was 12, interested in medicine, interested in EKGs, and interested in not killing people. And that's pretty big, all right? And so later, that really had a powerful effect on the course of my life. So I'm riding with the car with my Dr. Dad, and we're listening to all these tapes about how to treat blood pressure and cancer and heart disease. And, my dad was a huge influence. My dad is a very ethical and moral and smart man who really cared for his patients so that he would go out of his way and make house calls to dying people. I remember one where grandma was dying in the back room of lung cancer and everybody out in the family room is sitting there smoking cigarettes. So I decided to be a doctor. In high school, I decided to find where's the best school to go that actually will get you into medical school. So I went to Furman. Furman had a high grad rate. If you got through their program, which was not easy, you could get in. I went on to the Medical College of Georgia, where I continued to kind of be a gunner and focus on trying to do the best and make the highest grades, and got through there in the top 5%. Went on to medical school in family medicine. The idea here was I wanted to do everything. When I was a medical student, I did all these rotations, and I wanted to do it all. And this was as close as I could do to doing it all, and it also, again, was kind of following my dad's footprint. I went to Dalton Family Practice, where I worked for a couple of years, and then, to be honest, kind of my world fell apart. I got really depressed because I was going through get there, and then I got there, and I was like, well, what's next? And so really had a lot of emotional problems at that point. Moved to North Carolina for a bit, and finally landed in Canton. And I've been with Piedmont Healthcare since 1999. Now, the other thing that went along this path is, in college I gained about 50 pounds. I lost it all. Then I got asthma for a few times, and I gained it all. And then I would go to quick weight loss and all of these other things. So I got asthma. I was put on steroids for about 2.5 years, gained 75 pounds. And I don't know if y'all know this, but that really drives a carb addiction. If you look up addiction in a psychological manual, it's not there. But I'm here to tell you I believe that it does. And then we already touched on the doctor lounge. So I did Weight Watchers twice. I counted points. I dipped my food. I did Nutrisystem, didn't like it very much because the food was expensive and got boring. I did Suzanne Summers, Body for Life, South Beach, Mediterranean, and quick weight loss. What's missing? Low carb. Why didn't I do, well, that's
So perfect. Yeah.
well, low carb never occurred to me. Well, yeah, and MetaFast and all of that. So never occurred to me. So how successful do you think I was? Not very successful.
50%.
So the reality is, any one of these things, you're going to have some people who succeed, and they're really good at marketing those people. And I'm not against any of these things. If it works for you, it works for you. But the problem is, for me, and I don't know how many of you kind of understand this, I had a dieting mentality. All right? I'm all in and get whatever success you get from it until you're all out. And that is a fundamental shift in my understanding now about this whole experience. I try to tell people, change your way of eating. Let your default way of eating be how you eat when you travel, when you're on a cruise, when you go to a wedding, anything. And we'll talk a little bit about the psychological aspects. So this is Roxanne and I. This is Christmas 2011, the year we got married. And interestingly, we didn't have body dysmorphic disorder. I thought she was really hot. Here we are on our honeymoon, and I think the whales out here are trying to get us to come back join the pod. And 2 years later, her sister's kidneys failed. Now, her sister Vicky had polycystic kidney disease, which means she knew for 20 years that they would ultimately fail. And Roxanne had told her all along, I'll give you a kidney. And I work at Piedmont. We thought she had a couple of years. Her kidneys got infected. And I don't know if you know what polycystic kidneys look like, but hers were about this big each. And they were literally bags of pus. And they surgically removed them. So she went from, I've got 2 years, to in 3 days, they came out. So we're riding to the hospital at Piedmont Hospital. On the way, she calls the transplant office to say, I want to be tested. And they took some data, height, weight, age, other health problems, and told her that you have to lose a lot of weight before you can ever be tested. Well, that was really, really, really difficult because both Vicki and both Roxanne are crying. And I'm sitting there in the hospital room thinking, well, what can we do? And you know doctors and you know husbands, we want to be problem solvers. We want to fix everything for everybody. And so I came up with this bright idea that I would have never considered before that, and that was, well, you know, I've heard that bariatric surgery is safer than I had been taught. So I had been taught bariatric surgery is kind of a last-ditch effort. Bariatric surgery is something that you know is high risk and that a lot of people don't succeed. So we went to a bariatric surgery seminar, and I'm going to recreate that scene for you a little bit because it had a very powerful emotional effect on me. So we show up and we're going to show you slides that the doctor showed me showing that we have an epidemic. Now, I knew that it was a problem, but this is very impactful. We found out that surgery is a tool that might help you manage this disease, but it is not a cure. And we found out it was safer. So I was told it had a 3 to 5% chance of mortality. Compare that to an appendix, which is like 0.1. All right, 3 to 5% seemed pretty high for me. I had just fallen in love with this woman 2 years before. We found that of all the people who meet criteria for bariatric surgery, only 1% get surgery, and a lot of them may regain their weight. So who takes care of the 99%? That was a fundamental thing that hit me. that's why I became an obesity medicine doctor. Not because of appearance or attraction or anything like that. So how do you figure BMI? BMI is literally saying, how's your weight for your height? Your weight in kilos divided by the height meters squared. And so, you know, you might argue that the problem is that not that we're too heavy, it's that we're all too short. So these things come from the CDC, and this is what he showed us in the seminar. And I want to show you, it's a survey they do every year by calling up thousands of people from the CDC and asking a bunch of questions about your habits, your running, your smoking, your alcohol, your height, your weight. And if you look at this, 1990, and we're going to go back before that, the white, that's no data. Down here, the highest rate of obesity was 10 to 14%. You fast forward to 2010, no state has less than 20, no state except for Colorado, they're here still, but the rest of them are 15 to 19% and then 20 to 10. So we keep having to come up with new colors. All right? All right, 85, again, white is no data. So I'm just going to show you what he talked about. And this is a lot of slides, but it's brief. And I want you to look. And so 91, again, new colors. And you're going to see a trend here. These folks, they always lead the way. They're the poorest state, and they lag in education. I guess we have to be best first at something. And we can go faster. But the trend is we have got an epidemic on our hands. Now, how many of you think that if we had this trend in cancer, TB, Ebola, that we wouldn't have a national epidemic and an outcry? You lose 6 people to vaping, and they're talking about outlawing a whole industry. Obesity,
It's a food industry.
obesity, we spend in 2016 $1.4 trillion in obesity and obesity-related care, and it's killing people. We spent $55 billion, 750 times less in the opioid crisis that year. What do you hear about all the time? And so I joined the Obesity Medicine Association. I left that bariatric surgery conference after looking at those slides with a deep sense of shame because I didn't know what was going on. I felt some responsibility for all the patients I'd taken care of. I felt a lot of frustration because I was 294 pounds and I didn't know what was going on either. So I started studying, got 7 textbooks of obesity. I joined this group, the OMA, and it started to dawn on me first that this is a disease. Only 4% overeat. If you have obesity, only 4% overeat. So, you know, here's my definition of obesity. And it's a paraphrased version of the OMA. Obesity is a disease that's not your fault. So, when people come to see me, that's my starting point. And when you come back, whether you're succeeding or not, that's my fundamental starting point. And because it is a disease that's not your fault, shaming and blaming the patient doesn't help us at all. My job now is to take a lot of responsibility to help you guide your way. All right? So obesity, once you get it, becomes a chronic relapsing disease. That also is not your fault because there are metabolic processes like slowing metabolism, raising hunger hormones, lowering satiety hormones. Got board certified, and this is because all the doctors I talked to at Piedmont, the family doctors and internal medicine doctors who I was trying to get rah, let's all learn about this, they go, not interested. But you are. If you get certified, I'll send you some patients. So that's the path I chose because I want them to, by example, see a different way. So I talked to the CMO of primary care, and he said, well, if you can show us by putting together a presentation in the quality committee that what you're going to do, which is not part of government guidelines, is evidence-based, if you can make that case, we'll support you. And I have to tell you, Piedmont, I bounced around before I landed at Piedmont. Piedmont was one hospital, is now 11. We had about 500 doctors when I joined. We now have over 2,600. And it's really cool to be part of something that's growing and that's willing to support me in this endeavor. Now, a lot of the other doctors still think I'm nuts. I'm not. I'm evidence-based. I'm just not bound to the guidelines. All right? I'm completely evidence-based. But Piedmont deserves a lot of credit, and I really appreciate it. So I started doing consults in January of 16, which means the other family docs in internal medicine, cardiology, and orthopedics sent them to me to say, we don't know what to do. Can you help us out? And then I went full-time in June of 16. So after reading 7 textbooks of obesity, 1,000 scientific papers, hundreds of lectures, 30 books, including Good Calories, Bad Calories, Why We Get Fat, In Case You Get Sugar, all of those things, and more, I came to the conclusion that keto is the most evidence-based and best way to fight obesity and diabetes. Now, there are some people who take it a little further, but this is so fundamental to getting better from the physical ravages of obesity, the psychological ravages of obesity. And then you're going to hear from Jessica and Clara later that it's more than just that. You know, I started down the road focused on obesity, okay? So there are other stuff. Yay! What's killing us in this country? Obesity, diabetes, insulin resistance and metabolic syndrome, fatty liver, PCOS. Oh, it's good for seizures. Talk about that more later. Blew my mind. We're not talking about this in the medical community other than to say, well, it might be okay for weight loss, but you can't do it long term. The reality is you can do this long term as well as you can do any diet long term. We have emerging science that is good for cancer. All right, if you want to see a little anecdote on that, watch the movie The Magic Pill. But there's also research coming out of Dom D'Agostino's and also Tom Seyfried at Boston College. It's also showing promise for dementia. If you want to look up Stephen Cunnane, he has some research. There's actually a YouTube video of him doing research about PET scans. It's good for migraines. So Roxanne and I was actually fortunate enough to train with Dr. Westman. So we go to Durham. I work with him for about a week. We go to an actual meeting of his low-carb support group, and we're going around. Everybody tells why they're there. And I'm sitting there, well, I used to be 294 pounds. And it's helped me get out of a lot of trouble, and I know why I'm here, but why is this skinny 21-year-old woman across from me here? Why is this one down here? Oh, she had migraines and she had panic disorder. It's good for traumatic brain injury and glycogen storage disease. So glycogen storage disease are people who cannot make glycogen, which is a sustained fuel for the muscle. And so what they have to do is eat carbs all the time to keep their muscles going, and they're on a yo-yo. You put them on a keto diet, their muscles are happy with ketones. All right, so that's how I got here. Now, what Jimmy said is, this is low-key, don't sweat it. You don't even have to do slides. Just talk a little bit and then ask questions. And so what I want to do now is just throw it out for questions, and we have a later talk about how to talk to your doctor about keto. I think that's pretty important, and we can go on from there. But any questions? Yes.
I've had malignant melanoma twice and survived and thrived, but it was mainly through surgery. And I'm fully keto adapted. My question is, how does keto help cancer? Because I also get a lot of basal cell carcinomas too.
So, excellent question. So for the people who couldn't hear or for the recording, the question is, I've had malignant melanoma twice, basal cell carcinomas. He's fully keto adapted, and how does keto help cancer? So it's an interesting story. The answer goes way back to the early 1900s. There was a guy named Otto Warburg who found that most people's cells can burn fat or they can burn sugar, and most Americans on the SAD diet, standard American diet, burn sugar. All right? And so most of the research that you see about cancer or fat or any kind of dietary thing is in a background of a high-carb diet. All right? And so that's really fundamentally important to understand. So with the exception of just a few kidney cells, red cells, your body, all of your body can burn fat just as well as it can burn sugar. Any of the sugar required for life can be made by your body in the absence of zero carb intake. Now, when we get to cancer, the thing is those cancer cells were shown by Otto Warburg, they lose the ability to burn fat. So they require sugar to live. Well, the other bad thing about cancer cells living is they proliferate and they start spreading and killing the next door neighbor cells. All right, they kind of run amok. The idea behind keto helping cancer is you're going to reduce the stimulus for the cancer to grow. All right, you're going to reduce insulin, which is like growth hormone for everything. All right, you're going to reduce glucose availability, and then therefore the cancer cells should be at least less likely to grow and better able for your body's natural anti-cancer techniques to work, and also whatever other surgery, chemo, or radiation that is part of the treatment plan. Now, just here's a little disclaimer. I'm a doctor, but I'm not your doctor, so don't totally take this, don't take this as totally medical advice, but it's an interesting idea. Anybody heard of a PET scan? PET scan, positron emission tomography. What they do is they usually inject radioactive glucose into your body, and it goes to the cells that are highly metabolic. Well, one of those cells is the cells of your heart, the skin, and the GI, but also cancer cells. All right. So, in one of the talks, Stephen Koenig, he's imaging people with Alzheimer's, and then there's one with Lewis Cantley. They image people with cancer, and what you see is that the people on a keto diet, in Koenig's state, the brain, the metabolic rate of glucose use goes down because the brain likes ketones. On Lewis Cantley's slides, you'll see that the heart, which in the pre-keto diet thing lights up, well, it goes down and is really nice and quiet because the heart likes ketones. So these are the emerging science. This is the stuff that says, hey, this should work for a lot of things. And so there's a lot of interest now in treating heart failure because it's been shown to improve heart failure using keto. Now, some people would tell you that keto is perfect for all cancer. I actually have a hypothesis that it would be better for those cancers that light up on the PET scan. But that's just that would be a great research study. If you get cancer, still, do what you're supposed to do. The crazy thing is that in cancer centers across America, the standard is they're more worried about that you eat at all than they are what you eat. And so they'll be giving you peanut butter and crackers and cookies and Ensure and all of this stuff while you're under treatment. And what they don't know is you would do better with keto. Yes?
Wouldn't one want to extend it and make it even better than keto and go carnivore?
So the question is, would you want to extend it and go carnivore? So if you don't know, carnivore is kind of the latest advance in keto, and the answer to that is maybe. Right now, carnivore makes sense on a lot of people. If you've ever heard of Ken Berry, Ken Berry kind of had his own personal experience with carnivore where he had some inflammation and GI issues. He went carnivore and it all got better. And Michaela Peterson went carnivore for autoimmune and it got better.
You know as well.
And
Sean Baker.
Yeah. And then Amber O'Hearn. And so there's a lot of right now anecdote and things about where it should work and it should make sense and it makes perfect sense. But so far we don't have the level of the evidence that we have for the keto. So I'm not at all opposed to carnivore.
What about S.K. Norton with oxalates?
So Sally Norton
Yes.
believes that oxalates are also an inflammatory mediator for a lot of people. Probably, and Grundy believes that it's lecithins. And then and so I think that they all have a lot to say. I think they all should be listened to and believed. And at this point, you become your own N is one experiment. So, Dave Feldman and Jimmy Moore are the two people that I think are probably the biggest N is one experimenters. So if you want to eliminate oxalates, it makes sense to try that and see. But at this point, I don't think we have enough evidence that says everybody is sensitive to oxalates. Oxalates would be things like spinach. There are a lot of things that have lots of oxalates that you might on a keto diet would think is good. Kale. And so nightshades are another thing some people impugn. At this point, we would say that the evidence is anecdotal, but it kind of makes sense. So if the way I would look at it is, we are a big family keto. It's best that we accept each other eating however you want to eat, as long as you feel good and are making the progress on the metrics you want to make. Yes?
What's the most common consequence or symptom of oxalates?
Well, if you ask doctors, it's mostly kidney stones and gout. All right? But the other thing is that the marker for that is high uric acid. Now, also, if you ask doctors, this is the standard medical stuff. High oxalates, unless you have symptoms, they ignore them. If you have high oxalates, the other big reason for it is if you have cancer, say leukemia or lymphoma, and the therapy is so successful that you lyse a bunch of cancer cells, there'll all of a sudden be a bump in your oxalates. And for that reason, they will sometimes have kidney stones or gout flares, and they'll give you IV allopurinol or colchicine. So, but if you listen to the people who are sensitive to oxalates, it can be a response. You can have inflammation, you can have brain fog, you can have joint pain and skin rashes. And at that point, you have to, the science isn't there, but at that point you have to listen to your own body. And I wouldn't have a problem at all with you eliminating oxalates as your own therapeutic trial. This is where I differ a little bit from standard medical doctors, because if they didn't learn it in medical school, it's automatically BS. All right? But I've kind of gotten out of that. So one of the problems of growing up like I did is that I respected the authorities and the panels and the guidelines and all of these three-letter organizations like ADA, AHA, Ansel Keys, and blah, blah, blah. And it turns out they were all wrong, so you have to start questioning everything. And one of the things is you've got to listen to your body. So a lot of doctors won't listen to that, but I'm perfectly happy for people to do a therapeutic trial to see how you're doing. Yes?
Just a brief follow-up. You mentioned uric acid and kidney stones. Do oxalates, or are they believed to have any impact on gallstones, inflammation of gallstones?
Not to my knowledge. That's mainly a byproduct of dehydration, inadequate fat in the diet, ironically, and also how your body breaks down red blood cells. So most of your bile is coming from the breakdown of red blood cells, which is natural, by the way. They only last about 120. And then the rest is secreted by the hepatocyte, which means liver cell. Now, the other thing about oxalates, there's a real interesting story about kidney stones, and I'll abbreviate this very much. In the 70s, if you had kidney stones, the most common one was calcium oxalate. So in the 70s, the advice was don't eat calcium. Don't eat calcium, don't eat calcium. And it turns out that didn't work out so well, because then we didn't help the kidney stones and we got osteoporosis. It turns out that the problem is the oxalate is the primary driver. And if you give calcium orally, it will bind the oxalate in the gut, and it's relatively insoluble, so you don't absorb it and it goes out in the poop. All right? If you get oxalate in the blood, also it's relatively insoluble, so it's very difficult for your kidney to clear it. And so that really turned it just 180 degrees. Now, again, calcium intake and supplementation was advocated for osteoporosis in women, and no intervention comes without a little bad news, because high levels of calcium intake also can increase your risk of cardiovascular disease. So, it's interesting.
I'm curious if high level is. Has there been any thought, the combination of high calcium and high fat, if that might reduce any problems with high calcium?
Well, to my knowledge, no. High calcium deals with things like too much intake, and also your parathyroid hormone, and your bone metabolic rate. High calcium can also be a consequence temporarily of a fracture, like a fracture, a compression fracture, or cancer eroding into the bone. So there are a lot of reasons for high calcium. But that raises a larger picture. And the larger question is, when you talk about one micronutrient, macronutrient, when you talk about one factor as the cause of all disease, you have to look at it in the context of everything else. And that's why it's so hard to say that saturated fat is bad, because it's been studied in the context of a high-carb diet. It's why it's hard to say that intake of oxalate or lecithins or any one thing is relevant to everybody. And that's kind of the problem with science at this point. Now, I am a believer in the scientific method. And I think that we need to be cautious about some of the trends, but I also don't believe that the guidelines are, when you get the wrong answer, you're supposed to change your hypothesis. They've gotten the wrong answer on saturated fat so many times, and they haven't changed the dietary advice. To me, the fundamental principle is to restrict carbs and sugars and starches. That's the fundamental basis of it. Do you need to eat low carb, high fat? That's a good question. And I would say that if you have a lot of body fat to lose, the answer would be eat enough fat to make your food taste great, make you satisfied, but you don't need necessarily bulletproof coffee and fat bombs. If you're a young person who's lean and has seizures, you do need low carb, high fat. If you have a lot of autoimmune stuff, normally we tell people to eat moderate protein. Well, those folks might benefit from a little lower on the protein spectrum. So there are numerous adjustments. Low carb, high fat, well-formulated keto, no sugar, no starch, low carb, healthy fat. There are a lot of monikers, carnivore, and that's when it becomes a journey of what's going on with you. There was something else that prompted me to say, but I lost it. Yes?
With the vegetables, I believe you have to only ingest fermented vegetables. Because it's pre-digested for you. We're
Right.
not ruminant animal.
Right.
You can't eat grass.
Well, actually, that brings up a good question. So, do you know, I would say that there are some people who do well with that. and there'll probably be more that do well with that. But do you know the absolute requirement for carbohydrate intake and the absolute requirement for vegetable intake?
None.
Zero. How many of you have heard of the Bellevue experiment? So the Bellevue experiments concluded in 1929, and the interesting thing is that it was prompted by a Swedish anthropologist, Stephenson, and his first name starts with a V and I cannot pronounce it. But after 4 years in the Arctic with the Inuit Indians, he came back to the big cultural center of the Northeast, and he said, you don't have to eat any carbs at all.
Oh, yeah.
And he was branded a heretic until the meat board said, we'll sponsor a program at the Bellevue Hospital. And back then it wasn't just for psychiatry, by the way. And they ran a study for a year where they only ate meat and fat and no veg. Now, this was heresy because in the early 1900s they discovered vitamins. The Limeys had already figured out that lime would help you not have scurvy. They had at this point decided that you had to have vegetables and you had to have fruit to live, which was totally wrong. They proved it. At the end of the study, the lead researcher, a guy named Eugene Du Bois, said, sorry, the experiment failed. They were still healthy.
Maybe try to prove them wrong. Yeah.
So,
They were getting their nutrients from nutrient-dense liver. Liver has everything in it.
right, they were getting actually from liver,
Right.
kidney,
There's enough
heart,
vitamin C in liver than
organ.
there is in most vegetables.
They were getting brain too,
Yeah, exactly.
head to tail.
There you go, nose to tail.
Right,
Dr. Paul Saladino.
yep. And also, what was his name? Danny Vega.
Yes,
Yeah.
yeah.
The awful truth.
Sean Baker's been on this diet of basically
Right.
steak
Right,
and eggs and whatever, and he's thriving.
right. Well, that's what we mean by, I think you have to give that serious consideration. And Michaela Peterson had a lot of autoimmune. There's still some meat she can't eat. So, at this point, the carnivore diet has a solid basis for exploring and for consideration, and I don't have any problem with people exploring it or trying it. The big problem with the keto diet or the carnivore diet, what would you guess is the biggest concern that I would have as a doctor or somebody else who's a keto diet? What would you say is the most concerning?
Methionine and glycine ratio?
Close. It's even more fundamental than that. It's the drugs you're taking for other stuff.
Right.
So blood pressure medicines and diabetes medicines, for one thing, insulin and the medicines called Amaryl and glipizide and all of those things cause you to gain weight. They cause you to have high insulin. And when you go keto, they can be too strong. And so the biggest concern I have seen in my office are people who get keto because it's popular. And they end up hypoglycemic, which can be dangerous. So one of the greatest things about keto is its popularity, but one of the scariest things is that people who have a lot of other disease or who take a lot of medicines, those are the folks that we would ask you to see a keto diet. If you don't have to worry about that, I think that this can be a healthy diet for anybody on the planet. Yes.
Okay. Are there supplements you're supposed to be taking while you're on the keto diet? Or the keto diet is, I'm not in ketosis. I keep trying to go into ketosis, and then I get leg cramps, and I get migraines, and I get I feel horrible.
Right.
So then I quit.
Right.
And go back.
All right, so the first question is, are there supplements that you should be on? The answer is a lot of the ketone supplements and other supplements for keto, now that it's all popular, might help some, but the most people they help are the people making the product. The biggest supplement you need is sodium. Salt, salt, more salt. And it's so crazy that we're so afraid of salt. In terms of, if you want to go a little deeper, bone broth or broth would be better because it has calcium, magnesium, potassium, as well as the sodium. And that is the thing. So what happens is you lower your carbs, it lowers the insulin, your kidneys dump salt and water, you kind of dehydrate, your stools get a little hard, you get muscle cramps and low energy, and it's the salt. So it doesn't have, you can, if you're a purist, you would get a raw salt, a natural salt, pink Himalayan sea salt, or some unrefined salt. But Redmond's is another brand. To me, it's more important that you get salt, so I don't really care if it's bouillon or bone broth. If you're doing bouillon and you're still having cramps, add magnesium. If you're still having cramps, add some potassium. And if you want it through a supplement, milk of magnesia or other magnesium such as Calm is a good choice. If you need potassium, Morton's light salt. But then the easiest thing is to go to broth because it has all of it. If you're still cramping, vitamin D might help, but that's anecdotal. Anything else?
Tell us what you think of artificial sweeteners.
Ooh, good. All right, I might step in it. All right. So first of all, artificial sweeteners, I had changed the name to non-sugar sweeteners. And the reason is that we now have stevia and truvia and monk fruit that are arguably from a plant. Now, they are highly processed. In the family, the Big Ten of low-carb keto folks, there are widely varying opinions about the non-sugar sweeteners. And there are a lot of reasons for it. Does it spike your insulin? Possibly. I can argue that because of the first phase insulin response, you think about something sweet, you're going to spike your insulin. The other thing is that non-sugar sweeteners are new to the human food supply. All right? Prior to the 1960s, 70s, they didn't exist. And we had, we as a human being did not evolve to eat this stuff. All right? And so then it comes down to, should you do it at all? To me, the biggest enemy is sugar and starch. The biggest way when you go low carb, you're going to crave sugar and starch. That's inevitable. To the degree that you crave it kind of depends on how addicted you are to it. But the better you stick with low carb, no sugar, no starch, it will go away. But how do you bridge the gap from I'm craving it, jonesing it, to it going away? And so for me in my practice, I tell people that a non-sugar sweetener is allowed if you tolerate it. I do think that there are people who can't tolerate it because it still triggers their sugar addiction. There are some that it will blunt their weight loss. There are many, for instance, that will get migraines. You mentioned migraines. So NutraSweet is a common migraine trigger. All right, it's the blue packets. It's Sprite. It's Coca-Cola Zero or Diet Coke. And so there are a lot of them that are not going to be tolerable. You have diarrhea, a little IBS, sugar alcohols might just tear you up. Okay, erythritol and xylitol and things like that. Some people won't like the taste of saccharin. Some people won't like the taste of truvia or stevia. And so there are huge patient-to-patient variability. How many of you have heard that the artificial sweeteners could cause cancer? How many?
Yeah.
All right. Do you know where that came from?
Yes. The saccharin thing where they fed the rats the equivalent of 17,000 cans a day of Diet Coke and the rats got cancer?
Close. So Lauren said that it came from the sugar industry. They fed rats 17,000 cans of saccharin.
The human equivalent of that much.
And the answer is yes, except for the last part. They got cancer. They didn't get cancer. There were 2 rat studies at different universities. They gave them, basically the study I said they fed them 800 times the amount of saccharin per body weight that we would recommend for a human of our body weight, and they grew tumors. Now, the thing is the media report said neoplasms, which most people in the media interpreted to mean cancer, but it turns out they were not cancerous tumors. But the sugar industry thought that was just fine that you interpreted it to be cancer, because it would scare you back into the sugar fold. All right? So far, There are lots of arguments about the non-sugar sweeteners based on they're new to the human food supply, and we should be cautious. But to date, to my knowledge, there's no evidence of that they actually cause cancer. And my simple family doctor way of looking at it is don't do anything 800 times more per day than you should.
Yeah, right.
I was just gonna mention stevia, because it's probably considered the most innocent of them.
Yes.
But I have a lot of clients that we figured out a year into their journey that, you know, they would eliminate all sweeteners, but they would try to add them back in, they'd add in stevia. They had severe reactions to that because it's a ragweed. And so many people didn't know that. It's not the fact that it's even a sweetener, it's that it is a ragweed and they are really allergic to ragweed. So, I mean, that came up, and it's amazing that that's part of the reason it's so individual. If you're not allergic to ragweed and you can tolerate sweeteners, it might be fine, but that might be a reason.
So Lauren, will the thing pick her up? Will it pick her question up?
I think so.
All right. So that is absolutely true. So guess what else cross-reacts with ragweed allergy? All right, and this is the thing. So if you're using a non-sugar sweetener and you tolerate it, great. But if you don't, that's a perfect example. The other thing that cross-reacts is watermelon, honeydew melon, and cantaloupe. So if you're allergic, and I don't eat that stuff anyway because of the carbs, but a lot of people will struggle because, oh, I'm eating this healthy fruit, and they're sick. So that's, you know, people's allergies and intolerances are extremely individual. You know, and that's where how my keto and your keto can differ, and we can both be okay. All right.
Thank you.
Thank you.